Hi, I'm Jacob Heilbrunn, the editor of the National Interest magazine, and it is my pleasure today to welcome two distinguished guests to talk about the COVID-19 crisis. One is Dr. William Haseltine, and the other is Dr. Kavita Patel. Both will address the question of where are we headed? What do the booster shots signify? And today turns out to be quite an opportune time to discuss this, since the head of the CDC, Rochelle Walensky, has just overruled her own advisors to expand the segment of the population that is currently eligible for a booster shot. I'll begin by asking each panelist to speak with an opening remarks of 5 to 10 minutes. Then I will ask a few questions, and I hope that you in the audience will participate as well. If you look at the bottom of your screen, there's a place for you to type any questions that you might like me to pose to our panelists. With that, I would like to turn to Dr. Haseltine to begin the discussion.
Well, thank you, Jacob. And it's a pleasure to join this discussion with Kavita, and I'm sure it's going to be an interesting one for all of us on an interesting day. The announcement, I think, caught many people by surprise. I have to say I was one of the people who was really pleased with the announcement. One of the reasons for that is if you look back over the last year and a half, we in the United States and many countries around the world have really been behind the curve in trying to get ahead of the pandemic. Many of our policies were based on hope rather than on fact, our policies that we thought might protect us. And I think the debate over the booster is a good example of that. Let's just go back and remember that at first it was thought it was a disease, might not be so serious, might be confined to China. Of course, that wasn't true. Second, we thought that it was maybe we could contain it from coming into the country by relatively weak border protection. That didn't happen. Then we really doubted that it could be transmitted by aerosols, or let's say even before that, asymptomatically. Some of our leading scientists said, well, there's never a disease, it's a respiratory disease I know of, that can be transmitted asymptomatically. Yet that is exactly what happened. And it was that very early misunderstanding of the nature of the disease, despite the fact that some of the colleagues in China were saying that's what was happening, that led to policies that were pretty sloppy. And we never really have caught up. We haven't really plugged one of the major holes that we need to do, given the seriousness of this disease, which is massive testing. There are some countries that would, if 1 or 2 people are infected, they will test the entire city of 5 million people in a few days. And they'll do something about it. If somebody's infected, they'll contact it through contact tracing. They're required to isolate. That's how you can control this. And we never did any of that. We underestimated what could happen, and we have paid a terrible price. We've had over 670,000 people die, I think unnecessarily because of that. And so when it came to the booster, so it would bring us right up to the current time. Vaccines have been phenomenally effective. I have to say, if there's one area that I've underestimated how well things would work, it would be vaccines. But I've always suspected that the vaccines wouldn't last very long. And it's really got to do with the fundamental nature of the virus. This virus is built to infect and reinfect people that have already been infected. That's its modus operandi. That's how it lives in a bat cave. It infects long-lived, immunocompetent bats that have already been infected by the same virus or a slight variant of it. And it does that in a lot of different ways. I've been writing and doing all the research to really understand how it does that. But we know there are viruses like that, like the flu, like many of the common colds, some of which are also caused by coronaviruses. Immunity doesn't last. And now we're seeing that. Now, it's a little bit more subtle than that, because the message that most people are getting is that, yes, it doesn't hold. Yes, it wanes for infection. It might even wane for symptoms, which you now know it does, especially against some of the variants. but it's going to protect us still from serious disease and death. That's where we don't know yet. We don't know that. We actually don't know it because we haven't had the vaccines go out that long. Over time, 5-6 months, we've seen many of the vaccines wane for infection. Will they protect us against disease, serious disease and death? That is unknown. Yet many would have us base policies on that hope rather than on the fact. Therein lies an issue. If you're going to make a policy for something as deadly as this disease, you'd better do it on the conservative side, saying what is the downside, not what is the hope. Now, we might be lucky, and this might protect us from serious disease and death. I rather doubt that over time, but we don't know. That's the whole thing about not knowing, is you really don't know. So policies, and I've written about this, I've said, I don't like the decision that the FDA advisory committee made. They came out, I think, on the wrong side of the issue. I think Rochelle Walensky came out on the right side. She made a brave decision to do what I think the administration had done. And it's a really peculiar situation where the political leadership decides to take a cautious preventive course, and the scientific side decides, no, we're going to place what I think is a bet on hope, which may or may not be realized. We hope they're right, but we don't know they're right. And therefore, I'm very pleased that the decision that anybody over 18 who has a reason to interact with the public on a broad scale and may be exposed, unwittingly exposed, will now be able to go and get a vaccine. And I hope that's a harbinger for more wide distribution. I understand people's concern about vaccine distribution globally, but I think we can, as I said, walk and chew gum at the same time. We can protect our people, and we have the capacity to make hundreds of millions of additional doses for the rest of the world, which we're going to give away for free. So I think we can do both. It's not either or. I think that's the end of my first opening remark. I hope I've been on time.
That was quite fascinating, and we will definitely follow up on some of your insights. Now I'd like to turn to Kavita, who is the author of an op-ed in the Washington Post recently that was quite critical of the Biden administration, at least as far as I read it, for sending confusing, mixed signals on the necessity for a booster shot. And Kavita, I'd like you to elaborate on that and give us your perspective on the virus in general.
Yeah, so it's, I thank you for having me, Jacob. And I can't, Bill and I, in just a sign of the times, we did not, rehearse or stage what we were going to say, because I think we're all three of us try to respect or weigh and balance the science. And I completely agree with him. Having said that, I have been, continue to be both critical and supportive of actions like what Rochelle Walensky did at about 2 a.m., where she overrode the fourth vote from the advisory committee of the CDC. And we can get into some of the machinations behind kind of why that vote happened the way it did yesterday and why she did last night what she did. But I can also be very critical because there was no need for what started as a leak to a set of reporters about the Biden administration wanting to push for boosters on the week of September 20th, leading to then kind of the president and like a mid-afternoon live kind of, East Room announcement, making this kind of grand gesture of, we're going to recommend Americans get boosters 8 months after their second dose, and we're going to be ready for it. We'll still be able to vaccinate, et cetera. That was just everything that you should not do, and gave fodder, because attached to that then also got conflated issues around vaccine mandates, and everybody decided to kind of make anything that actually did have the appropriate science, such as getting a booster shot in populations that will start to receive them today. All of that became diluted, confused, and I give shots out in my clinic. Even the most senior kind of medical directors around me were saying, so wait a minute, do we just start giving them on September 20th? And people don't understand, regular people even pretty educated people don't understand kind of what is an FDA process, this, that, and the other. And so it's unnecessarily confusing in a time when misinformation has this just incredible ability to get traction. And that statement, also having worked in the White House, I knew that the minute you say something like September 20th and put it out there, even though you'll listen to the tape, which I have, he actually says like the week of the 20th, but that's not what comes off. The minute you put yourself out there like that, you're inevitably going to find somehow a failure. So for example, things could have gone very poorly with ACIP yesterday in a number of directions, and there could easily have been kind of a very different outcome with little recommendation to boost, save for kind of a marginal group at this time. And that is entirely plausible. So that, and then I'll say something that was kind of also buried in the op-ed is that what I really fault the administration for, the confusing messaging around boosters that really pulled the American public into thinking that if they don't get a booster, they're kind of being withheld, something of value is being withheld from them. But then equally concerning to me, we have done nothing to set up kind of a informational infrastructure. For example, I'm in Maryland. I can look on something called ImmuneNet to see in the Maryland database, when Jacob, if you live in Maryland, you might have received a vaccine. Unfortunately, not all clinics have put in information into that database. And if you're in Virginia, you can't get access to that database. And if you got your vaccine in a pharmacy or in one of those mass vaccination clinics in Virginia, that's not necessarily recorded in Maryland. So how crazy is it that when the ability to just get those first shots are so important, and depending on, I'm going to bring it out for the sake of posterity, and it's a blank card, and I'm not selling them on eBay. I have to use these in my clinic, and I brought one for, how preposterous that this is like our best, database. And so I just find myself, we have been plagued, by policy kind of issues and things that I would say really haven't changed since Donald Trump, and need to be brought forward, information, data exchange, and then clear messaging being one of them. So the only other thing I want to add though, Jacob, I just kind of want to add, because I can't help but kind of with this booster announcement, it brings to forward like a very important point about what is the goal of vaccination in the first place. And I think that, the original goal of vaccination really was to protect against severe outcomes and death. But I think that there's been interesting data. We can talk about the details of the data if relevant, Jacob, but the interesting data that's kind of suggesting that there's actually like some validity in a goal potentially being like prevention of infection. There is no ability with a respiratory virus such as coronavirus to offer sterilizing immunity. So we could not have a vaccine. And I also think the public is confused. There was never going to be a vaccine that we could get that you would never get infected. And so from that point, we were only going to be able to kind of protect against these severe outcomes, of which we've been doing that effectively. But now it feels like, especially with the Israeli data, that there is some strong kind of data to support, and it's suggestive. Of course, we need more, but I think Bill said it best. Do you want to wait for the data to be perfect and wait to have something kind of in your hindsight, or do you want to take something that could be preventive and have, do the right thing? And also interesting, a lot of people, we can talk about global equity issues, happy to do that. I completely agree that ignoring a large number of countries, I've worked in other countries. I can tell you right now that even if the United States said we're going to give you 10 billion doses of Pfizer, countries cannot receive those doses, don't have the storage ability, don't have the staffing. So it's a lot more than just the vaccines. But I also do, kind of to Bill's copying that phrase, I do believe we can like walk, chew gum, design the gum at the same time. There's no reason that we can't prioritize what the science is telling us for populations, i.e. boosters, and also make sure that we don't lose sight on our obligation, as well as kind of what I think is an ethical and moral right to contribute to the global vaccination effort. I know that's a very charged, it's easy for me to say that. I'm a domestic policy person by background, but I think it's important to just state that. that I do think that the goal of vaccination, suggested by some data in Israel, is that you can actually really do a lot to kind of prevent transmission and widespread infection through this booster campaign. And they are doing 5 months from the second dose of Pfizer for ages 12 and up, which is incredibly, in the US eyes, would be incredibly aggressive, given the conversations that have taken place from the FDA and CDC advisory committees. And then I'll just, the booster rollout will be pretty messy because I could drive a Mack truck through one of the recommendations that was signed off. And Bill, I'm sure you found it as amusing as I did. You know, if you're 50 to 64, it's endorsed. If you have a high risk condition, if you're 18 to 49, you know, I forget, I think preferred, or who knows what that is, right? So really, practically speaking, 18 to 64 with obesity being a high risk condition, and 40% of the United States adult population is technically obese. So we've got a lot of people that will technically be eligible for boosters, and rightfully based on criteria would meet them. But I think that the CDC advisory committee, in phrasing it the way they did, probably is maybe patting themselves on the back that they made it a little more narrow than what the original application was submitted by Pfizer, which was very broad, probably too broad, which was everybody ages 16 and up, 6 months from then. And then let me just finally say that there's an issue about the high risk occupations, kind of a lot of back and forth. The effectiveness, so a couple of data points. There is no decrease in effectiveness for vaccines that I received as a healthcare worker, just because I'm a healthcare worker. So the effectiveness is similar to anybody of a general population, same age, et cetera. And that actually severe disease amongst vaccinated healthcare workers is incredibly rare, and that occupational exposure leading to infections is also incredibly rare. Where healthcare workers are getting infected is actually where everyone else is getting infected in community acquired infections. The challenge is, and healthcare workers are not the only high risk occupations, but I use them as an example since I am one and know the data. The challenge in that setting is that if I get even a hint of being sick, I'm out for at least not 10 days, but even longer potentially, taking me out of the workforce, or a nurse or a respiratory therapist who's like the most valuable staff person at this moment, sadly, is devastating. So I just want to say that because I think a lot of people kind of assume that high risk occupation meant that by nature of my occupation, I had a high risk of exposure in my occupation. That actually has not been shown to be true, which makes sense since I have so much PPE and garb on while I'm at work that it seems impossible for anything to penetrate the 10 layers I'm wearing. But it just will kind of, and then I'll close to kind of bring it back to a high note. So what do we know from this? We know a couple of things. We know that our public health infrastructure was broken, continues to be broken, will remain broken, and we should care about that. Scott Gottlieb, in his book, which I recommend, Uncontrolled Spread, I get no money from that, but has a very eloquent chapter kind of dedicated to, reforming the public health infrastructure in the interest of national security. Bill has written books that kind of also have like similar, conclusions that raise that similar consequence. I would say that should be a priority, and nobody wants to talk about COVID again, when we theoretically kind of get past this being a pandemic and it becomes more endemic. But we should probably have a very vested interest in this public health infrastructure, not just for future pandemics, people like to talk about that, but because there's so many other things that a crappy public health infrastructure miss that are important in society and security. So I'll stop there. I think I went right on time, hopefully.
That was excellent. We covered a lot of ground. I think I think we should turn to Bill to see if he wants to respond. And one thing that I found intriguing about Kavita's remarks, and Bill, you were talking earlier about the need to be conservative and that there's a lot we still don't know. And you outlined the various, the sort of the path that we took where we were groping in the darkness to find our way forward over the past year and a half, 2 years. What is your assessment of what Kavita was saying about the Israelis being pretty aggressive about pushing for the booster? And what explains the reluctance of the scientific panel to sign off on the booster. Why was it that the head of the CDC, I think it's fair to say, exercised real leadership? She took a stand, and a lot of times people in those positions don't do that. She did, to her credit. So what's going on?
Well, I think you put your finger on one of the oddities. It's hard for me to understand what both the FDA and CDC advisory committees do. I've actually written something in criticism of what they've done because I think they took a stand, which was, we just don't have the data. You know, I've thought a lot about the evolution of human intelligence and intuition and how you make decisions and what judgment is, good judgment. And it's the ability to make the right decision on limited data. If you're making big decisions, you very often don't have all the data. And those people either survive, is there a bear in that cave or not? For example, going back to something quite primitive, is based on integration of a lot of knowledge and feeling. That's intuition. And you've got to do that in a situation like this. And when it's so important about public policy, how to protect hundreds of millions of people's lives, you better use every tool you have and not only rely on certainty. You can't get certainty in many situations. We don't have that certainty. And so I think it's a rare case in which the political leadership and now the administrative leadership took some very bold steps. Now you asked the question, who do I personally think should be vaccinated? I think everyone should be boosted. I think this vaccine looks like it should have been a 3-shot vaccine, like many vaccines are. You look at hepatitis, you look at human papillomavirus, it's a 3-shot vaccine. There's nothing magical about 2 shots. 3 shots does a heck of a lot better. Just look at the data. You know, it's 4 or 5 times better. It's just better. And the Johnson & Johnson vaccine is a lot better as a 2-shot and probably even still better as a 3-shot vaccine. So, you know, we speeded it along. We sped the whole process to get it approved as a 2-shot. And J&J caught up with a 1-shot. But that doesn't mean that was the final. It looks really, to me, just looking at the data and getting much, much higher protective levels that are likely to last, you know, another couple of half-lives longer, 6 to 9 months longer than the 2-shot vaccine for protection against infection, looks good. So that's what I would first say. I would say everybody who's had a shot after 6 to 8 months should get a booster. That's the conservative position. And that would eventually go for children as well. I'm for vaccinating children 2 and up, and perhaps even younger if the data shows that it's protective, because that is what we have. But there's a bigger point that and Kavita was making this point too, that I think is really important. The Israeli data shows me that vaccines aren't enough. You can get countries that are really well vaccinated, whether it's Iceland or Israel, the virus breaks through. And if you relax your mitigation measures, whammo, it comes back to levels higher than it was even before. Hospitalizations go up and deaths go up. Now, right now, the deaths in Israel, which are pretty high, as high as almost they've ever been, is mostly amongst unvaccinated. Haven't vaccinated everybody. And so people are relying on, well, it's the unvaccinated. There are vaccinated people who die in the United States. Vaccinated people die. Now, yes, right now, it's a low percentage, but everything could be a matter of time. The initial 95% was a matter of time, and I knew it at the time. And I believe it was oversold. Vaccinated, you're protected. No, vaccinated, you're protected for a while. Vaccinated, you may be protected from dying for a while. We don't know that yet, but that is where I think things are headed. And I think that based on looking at a very deep analysis of what happens with flu and others. Now, there's a whole community out there that's going to scream, hey, I'm a T-cell biologist, I'm a memory cell guy, and I know that that's going to save your life. Yes, we make great memory cells, but why do we keep getting infected?
Mhm.
And why do we keep getting the flu if our memory is so great? Why do the same coronaviruses come back year after year and make us sick if our memory is so great? I think our memory isn't all that great. And these viruses have learned to put a stumbling block in front of memory and outpace memory. You talk to a flu biologist and say, flu replicates so fast, it outruns memory. Memory isn't instantaneous. Memory takes a little while. And these viruses have all sorts of tools. I've just written, I think, 12 or 14 different pieces on all the tools they have to mess up your initial immune response. Not just the first round, but the second round. And if you look at flu, say, yeah, memory is good for you. But oh, by the way, if you have an immunological condition or you're old, it doesn't really work that well. Well, who dies from flu? Who dies from COVID? It's exactly that group that memory may not protect. So there are really good reasons to be conservative. But there's one other even bigger point I'd like to make, as I was making a little bit before, and that is vaccines aren't going to solve the problem entirely. They're good. They're the best tool we have. And I don't want that to be read to say I don't think everybody should be vaccinated, because I think I've made that clear. But we are lousy at public health. We are execrable at public health. We don't really test everybody. We do not contact trace. And if we found somebody who's been exposed, we do nothing, virtually nothing. That's how you controlled the virus for a population of 1.4 million people. So 600,000 Americans died, maybe 24 people died in China. And we don't like supposed to talk to China about China because that's authoritarian. Well, it's a society that works to protect itself, and everybody participates. And it's not because their arms are twisted. I don't believe you can make a population do what it doesn't want to do, as we're learning in America. We had a lousy president for COVID. We have a great president for COVID. But as Kavita said, we're getting some similar outcomes. And that's because of our people. So we are missing a giant piece of COVID control. And if we don't ever put that in place, and the reason, as Kavita mentioned, we are missing that is because we don't have a good public health infrastructure. It's just not united. She was talking about data collection of something as simple as who's been vaccinated, where, and when. We have no national database. You know, if I go between New York and Connecticut, they don't know who's who. And you go between Maryland and Virginia, you don't know who's who. We don't have that database. It's incredible to me that the knowledge of who's vaccinated and who's not isn't there. So we need to fill in that gap. And they're looking forward. There are some more things we can do. We will have preventive drugs. We will do what everybody has worked on HIV so long to do, which is find prophylactic drugs that are long lasting. So if you are exposed, you won't have to be isolated. You can get a jab or you can swallow a pill. That is going to happen. It's not going to happen tomorrow. It will happen. So then maybe, you know, things going well, we'll be able to get people to be convinced that yes, you should know if you're exposed, because if you are exposed, you should pop a pill and your family should pop a pill and you'll be protected. That may change, and that may be an impetus, I hope, for public policy to catch up to where we need to be to face this pandemic, because this isn't the last one and it ain't over by a long time, by a long shot. It just is not over. The hope that this is going to be behind us, I think, as Kavita said, it's moved to endemic, but endemic means it comes back every year, and maybe this thing comes back twice a year, because we've seen a peak in the summer and we see a peak in the winter 2 years in a row. Surprising, but that's the way it is. Those are some thoughts.
Holy moly. Usually or often we have discussions on foreign policy, and I thought that they were pretty bleak, but this sounds pretty daunting. Kavita, I wonder what is your take on what Bill just said?
No, I agree with most of it. I mean, I think Bill and I are speaking for just, you know, I really am not trying to be opinionated or political. It's just we're looking at what's played out in the data and kind of what we're seeing. And so I I agree. If I were to kind of shed something of an optimistic tone, I would just say that, note the, keywords are, I hope. I mean, I do hope that there is some kind of like more durable immunity, kind of our immunity longer lasting. I mean, people have kind of said, quote unquote, maybe after this 3 doses, because Bill's right. There's, by the way, argument, and even I think some of the scientists from Pfizer have said, yeah, there might have been some, like, if we pushed the interval between the first and second doses, that actually might have been beneficial because of data from the UK where they had a purposeful delay strategy, different vaccines that they used in general, but saw that delaying that second dose was actually beneficial in kind of increasing efficacy. So some people think these potentially 3 doses might be it. I also remain skeptical. So I hope that's true, but I agree. But I also, I do feel pretty strongly that, we, if we haven't been kind of provoked by, gun violence, climate change, a number of other things, it's hard to see the public, the American public, really wanting to dig in on COVID and like do the post-mortem if all we can do is reassure people that they don't have to wear their damn masks anymore. I mean, that's where I think the public is at. I have become very cynical about our ability to kind of be global citizens, much less citizens of the United States of America, because at the end of the day, what people desperately want is to just kind of do what they want and live their lives. And even concepts like herd immunity, population health just don't ring true with a lot of people. So that's the challenge as policymakers or people who influence policymakers. How can we guide something that provides what I'd say is minimum protection, but knowing that human behavior, to Bill's point, is always kind of a, it's a crapshoot. And on many cases, you're on the losing side of that bet in what I've observed. And I think that a lot of people like to, I've talked about disparities, like we like to talk about inequity and disparities. There's a lot of talk about it, very few answers. I still see a lot of what I saw play out 18 months ago still plays out. So people, if you go to some of our hospitals in some of the hardest afflicted counties in Maryland, it's still like, 18 months later, somehow we haven't really made some dent in communities of color, people in Medicaid. I mean, those things have still carried forward. So, one day Jacob will return to talking about, Medicaid access or, rationing of care. That gets a lot of front page news because of states implementing what we call crisis standards of care, which just means that doctors have the ability to prioritize patients, things that but the truth is in our country, we've rationed care for a long time. And we've rationed it by pathways and access. We've rationed it through the way we've set up insurance benefit design, and we've rationed it by how people can afford to pay for things. So I just feel like COVID obviously affects us. The 3 of us would probably be much happier to be in person on a stage or wherever having this discussion. But in some ways, not much has changed. And that I think is how I kind of reflect on this for a broader message. Anyway, I know we have some questions, but I'm hoping I'm hoping that we can end on a more upbeat tone. And the upbeat tone is that they're modeling scenarios and other things give me some optimism that at least the next waves that we have will be smaller in magnitude, and we'll have still to Bill. I think Bill's right. We all need a booster, and that if we can get enough people, either I'm actually even okay, Bill. You're talking about treatments, which I think is an excellent point. There's an AstraZeneca monoclonal antibody that's actually been kind of approved by the European version of the FDA, and they have not submitted for an EUA in the United States. They might have, but by this time, but as of 2 weeks ago, they hadn't. It's a one-time intramuscular injection and found durable kind of immunity for 6 months. And given the conservative leaning towards embracing monoclonal antibodies for some reason and not vaccines, I'm even willing, Bill, to say, okay, fine, if you don't want to get vaccinated, but you'll take Governor DeSantis's intramuscular monoclonal antibody that gives you 6 months, I'll take that. And so I do feel like we might be able to get to broader immunity that gives us kind of more quiescent periods of time.
That's $2,000 a shot.
Oh, I agree.
rather
Oh,
than
I mean,
rather than $12 for the government to pay.
and trust me, that's how desperate I am. You think, I mean, we got monoclonals on our hospital shelves. What are those at 11, 12,000? I mean, there's no use of resources that's more efficient than a vaccination program, but you know where we're at. I mean, this is some weird, I don't understand it. I'm not going to try to ask Jacob or Bill for you to explain it to me, but no idea why people are willing to put in like an emergency authorized, to your point, incredibly resource intensive medication that when there is a, $12, $40, whatever.
It isn't rational, it's political.
Yeah, so, but
That's
I'm
the
even
answer.
willing to take that.
And so from the politics, it's rational. From a strict
That's how
scientific point of
desperate,
view, it's irrational, but
that's
it's
how
got to be
desperate I
rational
am.
from their point of view.
I'm telling you that that's where I'm at. Like, if we can get
And
to
I think
25%.
people see it to their advantage to push that line. And
Yeah,
their advantage may not be your or my advantage, but it's their advantage.
Right. And so that's how I'm kind of at this stage, like, fine, if that's what you want to do, even I'm willing to like look the other way and say, oh, we'll do it just to get us through.
We hope that there's a simple pill you can swallow.
And Pfizer, a protease inhibitor. I mean, yeah, there's so many things that are interesting parallels to HIV. And it's both depressing when I think like, why didn't we learn this? Like how many years did we fight this fight? And it's depressing. But what worries me the most when doctors and many more hospitals and doctors are vocalizing that they don't want to treat unvaccinated patients, or that vaccination status should be a reason to refuse. I remember that, I was in medical school when we went from GRID to HIV. And I remember fellow medical students and actually attending physicians that did not want to take care of HIV patients. And so Bill, it reminds me of that, and it worries me.
It reminds me of when I was first doing HIV research at a cancer hospital. A lot of the doctors said, you can't do that because it's a risk to our patients. And we had a very wonderful president who said, listen, it's my responsibility to make sure it's safe. We have the people who can do it. Bill and our other scientists have unique capabilities. We're going to make sure it happens because it's our responsibility to our country and our people to make sure that we can do this kind of research. And that was very brave. It was, you remember the panic in the early days. It was not, I was a young professor, you were a student.
And I give George, you think about George H.W. Clinton, George W. Bush. George W. Bush too, on a lot of what he did to advance PEPFAR. Anyway, you'd think our country would have learned a little bit of this, but when I hear people say, I don't want to take care of unvaccinated people, it can't help but think of that, anyway.
So I have a follow-up question to both of you. So where does this end? If we are in this outlook is this bleak, let me ask this in a practical way. So when you go through Manhattan or downtown DC, the office buildings are pretty much a wasteland. Are we looking at possibly another year, another 2 years, or we just don't know when people are going to actually go back, when it's safe for people to go back to the workplace?
Let me take that first, and Kavita is going to share her own perspective. I can tell you what I worry about. I worry about what I'm seeing right now in Great Britain, what we saw in Israel, what we're seeing in many countries that are now saying, or Singapore, let's take Singapore as a good example. We can't afford as a nation, as a people, to maintain public health measures, even though we know that vaccination and public health measures are what we need to do, and we know that vaccination isn't enough. And what you see in Singapore is exactly what you're seeing in Israel. You're seeing a huge uptick in infection. And they're betting that that's not going to kill people. That's their bet. And I think it's a bad bet. Now, I don't think it's going to be a bad bet if people accept repeated vaccination, either biannual, either semi-annually or annually. If we accept that, maybe it's a good bet. But without that, I think it's going to be a very bad bet, and they're going to end up paying for it, not just with the lives of their older people, but increasingly with the lives of their younger people as this virus develops new tricks. The trick that it has is to get it, enter your body, do what it does, and get out before your first reaction, called an innate immune system. It's like a fire alarm goes off. This breaks the fire alarm in your cells. It just knocks it out 15 different ways. And then it gets out and doesn't care what happens. The burglar doesn't care if he burns down your house after he's got your goods. This virus doesn't care as long as it gets onto someone else. But if there's an impediment, it can get better. It can come equipped with a somnolic spray that puts everybody to sleep right away. This virus can get stronger, and there's evidence that Delta is actually doing that. Everybody's focusing on the outside of the virus.
Yeah.
But my goodness, it's making 1,000 times more virus. It's replicating faster. And it's doing that so it can get to other people faster. And that's what these viruses can do. So we've got to add and continue to add public health. So when I see a country like Israel or Iceland or Singapore, small as they are, giving up their mitigation measures and putting all their baskets into the vaccines, I get very worried, because that's a recipe for more variants, nastier variants, and a continuation. Let's take the extreme example, China. China is the #1 in the world at COVID control. They do it magnificently. Why? They came to Harvard School of Public Health, where I was, to learn how to control SARS. And they just executed the book. They did what we taught them, and we didn't do what we created. So now they're adding a layer of vaccine to that, but they're not going to give up their layer of control. So if one person in the city is infected, they test millions of people in that city, and they find that people are infected. And that will continue to do even with vaccines. And their economy is doing much better than others. Yes, they take a hit from time to time. You've got to close down one of the biggest ports, Ningbo or Shenzhen port, but they do it, and then they get on. I have offices and people in China that live a life completely different from our life and free from care. The psychological burden that we all have. I wrote a book called post-traumatic, COVID-related post-traumatic stress disorder. The psychological pressure that we're all under, people are cracking. They're going to drugs, they're committing crimes. It's and nowhere worse than the healthcare workers that Kavita referred to. You're a nurse, you're a medical orderly, you're exposing yourself. It's not even the exposure, it's the horrible pressure you're under and feeling that nobody's appreciating you. And there's a nurse in England who wrote a book about it, wonderful book about it. And your heart goes out to these people. But so what is going to happen in the long term? We don't know. We're getting better vaccines. We're going to get better vaccines. We're going to get better drugs. But we better not put our total hope on medicine. People have come to realize, the Robert Wood Johnson Foundation, for example, is that most of medical outcomes are socially determined, not determined by the hospital. You go to the hospitals in Chicago, and within 4 or 5 subway stops, people live 20 years shorter. Those are the people who are dying of COVID. It's not that they can't get to the hospital. It's their whole social, economic, cultural environment that's determining their outcomes. So we have a huge amount of work to do, not just on the people who are recalcitrant or don't see it in their advantage or their interest to take the vaccines, but people who don't even have the chance to do that. So we have a lot of work to do. I'm not sure we're up to the task. I hope we are, but this is really sort of putting into our face all of our problems that we have got to address. Fortunately, we have people in the White House and in our administration who understand what we're talking about. Whether they can do anything about it is another question. They're doing what they can. And we've seen one of them take some very bold action, but we hope others continue to do it too. And whether this is over in a year or 2 years or 5 years is not only up to us, a lot of it's up to the virus. Some of it is up to us if we can, pull ourselves up by the bootstraps to do what we need to do.
Kavita, do you have a quick take on that? We do have a
Yeah,
couple questions.
very quickly, I'll just say that the way I would summarize kind of the cumulus of like what you heard from Bill and like at least even the data that we're all reading, it shows that there's persistent benefits in these mitigation measures, especially just kind of sub bringing it down. If you're in a like poorly ventilated, much of the world, but also many parts of the United States, poorly ventilated, crowded kind of indoor environments, then and especially if we continue as a country. I mean, I'm one of the most kind of pro-vaccine mandate people there are, and I don't apologize about it, but I think it's because I've spent 2 decades now as a healthcare worker being told I have to get vaccinated for this and that, and my children have to do it for this and that, and I don't see harm in it. We have exceptions, and there you go. So if you're in these environments, of which there are many, I just mentioned the 40% obesity rate and other chronic conditions, then that's like it's a powder keg. As long as we continue to let like people go unvaccinated and also being very relaxed about acknowledging that what we didn't know, Jacob, in March, well, what we didn't want to acknowledge in March of 2020 about the nature of this respiratory virus and the role that even just ventilation and masks could have, well, then we're going to be in this like loop where we repeat ourselves. And I mean, look, we have like, we can have 2,000 deaths a day. I mean, we can have kind of a 9/11, 2,000 to 3,000 deaths a day. And now it's somehow like, oh, no big deal. So I think the public will just continue to be numb to it, but that we will see these kind of spurts and hopefully have a little bit more acknowledgement about how to be precise. What we've lacked in kind of thinking about moving forward because of this uncertainty around the behavior of the virus itself, we have lacked because of data, because of the lack of a public health infrastructure, the lack of kind of political will. We've lacked the precision to do something in a very targeted way. So now we're stuck with these blunt, crude measures. That's why we had to go back to everyone indoor masking. But yeah, so that's my take.
So we have a question from one of our audience asking, why is it that despite the efforts of the World Health Organization and other international organizations, they have been unable to close the North-South divide when it comes to vaccinations? And ask, is vaccination nationalism playing a part? And for example, why isn't the United States sharing its patents with the world despite Biden's promise to do so? Now, my own understanding, if I can interject here, and I guess you can correct me, is that it's not as simple as just sharing the patent. They actually need to be able to produce it. Now, that's not so simple. But Bill, would you like to take that?
Yeah, I think you put your finger on it. First of all, the US is doing a lot. I think it's donating over 1 billion doses, and we can expect we'll donate more. As we build capacity, we certainly have capacity to triply, quadruply vaccinate everybody in the United States. We are going to get bigger and bigger capacities of our 2 mRNA vaccines and other vaccines, as are other countries. So I think that is happening, and it takes a while. This is a new technology. It takes a while to build the capacity, but it's growing, and it's growing pretty fast. But there's something else deeply wrong with what's going on in the world, and that is we've known this was coming for a long time, and the rest of the world did not build regional vaccine capacity. It just doesn't exist. In most of South America, there's no ability to make vaccines. In almost all of Africa, you can count on 2 or 3 fingers where you can make vaccines. In all of Africa, they've relied on other countries to produce the vaccines for them. And that has been a dreadful mistake. In the Philippines, they even dismantled their vaccine production capacity, relying on others to make it for them. So, and it's not that it's all that expensive. You can build vaccine manufacturing much cheaper than you could build a 100-mile highway, a tiny fraction of the cost, or buy a couple of fighter bombers, or whatever else you want to spend your money on, or put into your Swiss account. So there's a lot of things that could have been done that never were done. And that's also emblematic of not caring for your people's health. I have a foundation that works called Access Health International, and we advise governments on health system strengthening. And as you look around the world, there's a whole lot of strengthening that needs to go on. And Kavita and I have mentioned what has to happen right here, because we have a lot of work to do here, and I've written and done a lot on that topic too. But I would say it's a shared responsibility of all governments to protect their people. Now, when it comes to these arguments, the rich countries are protecting their people and not us. It is the responsibility of a government to protect its people. Our president is doing the right thing, get us all vaccinated. But he's also doing the right thing and saying, when we can, we'll give as many vaccines away for free to other countries, which we are now going to do. So doing both is right, but not what people have advised us to do is inadequately vaccinating our people, under vaccinating our people to protect us here so that we can protect people there. Our president's job is to protect us. His other job is to help the world, but first us, then the rest of the world. If that's nationalism, I'm not sure that's the right word for it. It's good governance is another word for that. But helping all the world is important. But it's that same message that's so often heard. Teaching people to fish is a lot better than giving them fish. We should have, and people have tried, build these capacities overseas. In places like Africa and South America, we would be a lot better off. I hope that is one lesson that's come out. I've worked with some of the development banks now for some months now to try to encourage that, and there are some signs that's beginning to work.
Kavita, do you have anything to?
No, nothing. I mean, just, okay. So one thing to add around the North-South divide. There's also, just to speak to kind of global, it's not as if the World Health Organization and COVAX kind of had this incredible infrastructure and that, you know, kind of G7 countries have just been shuttering it. So yes, there's a lot of, you know, much smaller population, and we were kind of front in line, and you could argue that's because we subsidize through Operation Warp Speed a great deal of the R&D. All of that can be true, but it can also be true that it's not as if the World Health Organization, you know, doesn't face their own ills in thinking about a public health infrastructure and what their role. They're very underfunded and woefully understaffed from kind of pre-pandemic times, but it also wasn't something that all countries took as seriously. And then, of course, we know that the Trump administration, even though kind of withdrawing funds, much of the World Health Organization's funding, especially even from America, comes from nonprofits. So it wasn't necessarily accurate that Trump not funding kind of disabled the United States participation. But we're talking about, you know, a global infrastructure that wasn't as if COVAX was just up and running and ready to do all of this. So I think sometimes I often wonder, you know, what are we going to be able to do to improve that infrastructure? Is that going to be a priority? It feels like it's not. And so get back to Bill's point about nationalism and kind of what we have to do. So I just want to add that I think that goes without saying. So anyhow.
Well, I think it's pretty obvious Biden would be disemboweled if he did not seek to protect Americans first. I mean,
That's the thing, right. How many, who would tolerate, you know, a headline that said, you know, everything's good. We sent our 50 million doses, you know, to the Africas and they need them. True fact. But, you know, meanwhile, we had what number of deaths would we be okay with to do that? There's absolutely no way. I agree completely. And that's kind of both the clinical person in me talking and the policy and political person.
So one last question we had was about the first dose versus the third dose. Are we, in fact, depriving people of the first dose by going to the third?
I mean, sorry, I didn't mean.
No,
no. Just to bring it back down to like, I like to, you know, sometimes I wonder why I still practice medicine, and it's kind of in moments like this. Jacob, I throw doses away every single day. We will throw probably, Moderna is a 10-dose vial and Pfizer's a 6-dose vial. I can actually get 12 doses out of that Moderna and about 7 or 8 out of the Pfizer. But I usually break it open for 1-2 people and throw everything else away. So no. I mean, we might have kind of pockets of the country or pockets of areas where there might be the CVS in, Bethesda, Maryland that says, oh God, we don't have any. But you can come to PG County where I'm throwing stuff away every day. So no, I'm not worried about that.
I assume you're not worried either, Bill.
No, I'm not. We have plenty. We have an excess. I think Kavita said it well.
Right.
Now we're in an excess.
Throwing it away. Think of how
I
criminal.
wish people would be taking the vaccines we throw away.
And that, I mean, there's a requirement to kind of account for that, but I think we're woefully underestimating the millions of doses we throw away. And like, why isn't there, I mean, where is the outrage and outcry in that? And, there's a lot of good reasons we haven't done single vials of this, a lot of very important manufacturing reasons, but yeah, anyway.
So I guess just as a final, I'll just ask a final quick question to both of you. When I was on vacation in Montana, it was quite striking. The recalcitrance of the local population was in fact not only blasé, but I think somewhat jubilant about not being vaccinated and wearing masks. And that this was a sign of, I don't know if it's freedom or just the self-expression. So from what both of you are saying, this is going to continue to cause problems down the road. Is that correct?
100% yes. I mean, I just don't see, Bill, how can it not? What would the conditions be for which the answer would be no, are impossible. I mean, impossible that the virus would not act like a virus. I mean, what? It's not possible. It's not possible.
Yeah. And Bill, you're saying that actually a lot of speculation had been that the virus would become less lethal over time, but you're saying that right now it could continue to become actually more, there's possibility.
Right.
Well, actually, the SAGE group in London, I agree with them, and they've actually given a whole set of scenarios about what the future of the virus can be. This virus can be 100, let's say 10 times more lethal than it is. The SARS virus killed 1 out of 10 people, MERS killed 1 out of 3 that infected. This virus kills maybe 1 out of 100. So it has the potential to get a lot worse. It has the potential to become much more transmissible by any of like 30 different mechanisms. So it depends on the selection. The selection isn't to kill you. The selection is to get from one person into the other. But in doing so, it has to grow faster. It will make more virus in you. And as far as I can tell from the current data, if you get Delta, you have twice the possibility of ending up in a hospital from if you had Alpha or any of the other earlier variants. So this can get and has only gotten worse, is not gotten attenuated. And that is another one of the unfounded hopes that in fact, I just was reading about it today. One of the Oxford scientists who's in the vaccine said this virus has gone as far as it can go. Well, she isn't right. It is ignorance and stupidity and really irresponsible to say such a thing.
I agree.
You might even think about it, but if that happens, we'll be darn lucky. But everything has gone the other direction so far.
Yep.
And so we have no idea where this thing could be headed. There's so many ways it could get, it could go south. But maybe we end on a little better piece of hope. My personal hope from this is that we all learn that being responsible for our own health and the people around us is helping other people, and that they're being responsible for their health and the people they love will be helping us too. And we get to a better place in society where we understand more about mutuality, how our behavior impacts, there's how the larger world impacts us and how we individually impact the larger world. It's a reciprocal relationship. And I hope we can move from the adversarial position. I had a long talk yesterday with somebody whose job it is to run a big healthcare, 30,000 people healthcare system, and convince the 5,000 people who weren't being vaccinated
I mean,
they should be vaccinated.
that's
And
insane.
he managed to do that and get it down to about 700, and they think down to 500 people.
Without a mandate, Bill? No.
Without a mandate. He has managed to do that by listening to them. Now, his background is a clinical psychologist, right? That's what he is. So he understands how to talk to people.
That's what it
So
takes.
I think that, you don't shake your finger. He said, the worst thing is to see those people on TV shaking their finger, you're a bad person. He said, that will never work. You've got to engage them. Well, I think my hope is that we create an atmosphere where we can begin to engage all of us in a mutual dialogue, which be beneficial for everybody. And not to say they're bad or they're stupid, like I just said about Oxford scientist, okay, that trying to understand where she comes from, okay, or whatever. I think that is my hope, that we get to a place where we're our brother's keeper, and they're our keeper too.
Kavita, I'll give you the last word since Bill had the first.
Go get vaccinated. And if you already are, try to find someone in your social network, because there's absolutely someone, some two, some three who are not, and do what Bill suggested. It's the way I've been effective. It's kind of labor intense and one-on-one, but it will break through, and it's not the only point, but it's certainly the most important thing anybody listening or watching can do today.
Thanks profusely to both of you for participating in this. I found it highly rewarding and educational. And with that, I would like to end this panel, and thank you for watching.